blind men who are trying to feel the different parts of an elephant and they are trying to guess what it is. So instead of having a guesswork, if you can really peep into the body of that little preterm baby or a term baby who is having a hemodynamic compromise, that can perhaps give you a better understanding of what is going on and you can manage in a better way. So if you talk about the cardiac focus, I mean, the possibilities are immense, but I tried to summarize it in these many conditions, like it can help you to understand the dynamics in shock. So you can understand whether the shock is because of volume depletion. You can look at the cardiac output, the systemic and pulmonary blood flow. You can understand how the left heart is pumping. So, how is the systolic function? How the left heart is relaxing? So, what is the diastolic function? You can understand the RV performance, how the RV is performing. And then there are methods to understand the global myocardial functions as well. So, when we talk about shock, it can help you to understand whether the shock is perhaps there because of volume depletion, or there is some issue with cardiac output, or there is some issue with contractibility or diastolic dysfunction, and that can help you to guide your therapy. Then, of course, from the most popular use of functional echo since decades has been diagnosis of hemodynamic significant PDA, and that is one problem in extremely preterm babies, which can cause some hemodynamic compromise, and we should be able to look into that by functional echo. One of the important uses of functional echo in NICU is in diagnosis of pulmonary hypertension, both acute pulmonary hypertension, which can lead to hypoxic respiratory failure, as well as chronic pulmonary hypertension, which could be secondary to many other conditions, including chronic lung disease. Additionally, you may use functional echo as far as cardiac is concerned to understand transition circulation. If there is hypotension or poor perfusion in transit circulation, it can help you to understand what kind of medications you can use in natal asphyxia to understand the cardiac contractibility. Then, in conditions like diaphragmatic hernia, you can look at the heart and understand what would be the best kind of therapy to give. And then in babies who crash down suddenly, it can help you to diagnose tamponates, for example, a pericardial tamponade. And here is your video of a pericardial tamponade. And it's a simple putting the probe on the baby and just getting a four-chamber view. And if you had this kind of picture, it could be life-saving. So the possibilities are immense, and it's not possible to cover all these things in 45 minutes. But we'll try to have at least a snapshot and some idea of what are the possibilities of functional echo use in units. Now, coming to preload status, there are various markers to understand the preload or the volume status of the patient to understand if there is hypovolemia or whether there is normal volemia. This can help you to uh, decide whether you need to give some volume to the child or you can proceed. So, one of the very basics of functional echo is to do eyeballing. So, eyeballing means you just put the probe, and when you put the probe, whatever structure you see, you just eyeball, and based on your experience, you try to have a kind of impression what is happening to the heart. So, you can eyeball the chamber size. One of the important structures to see to assess the volume is the inferior vena cava. So look at the size of inferior vena cava and collapsibility. So the inferior vena cava, it will collapse. So when you inspire, when you take inspiration and spontaneously babies who breathe spontaneously, it will collapse during inspiration. And again, it will come to its original shape in expiration. So if it is collapsing more, if the collapsibility is too much, that means there is a possibility of hypovolemia. Then there are some indices like IVC collapsibility index, distensibility index, IVC aorta ratio, SVC collapsibility index, variation in aortic VTI, lot of parameters, almost many parameters which can help you to assess the volume status. Now, since this is more like an introductory class or just a sensitization, I've just taken three of them to make you understand how to use functional echo to assess the volume status. In scenarios where the perfusion is poor, we are suspecting that there is shock and you want to rule out hypovolemia, in addition to taking the clinical history and the examination. So one of the ways to do a quick volume status is getting a four-chamber view. So this is the first basic view which you all should know when you embark on the journey of functional echo. So for getting a four-chamber view, what you do, you keep the probe. The probe is kept on the left side, roughly say between 2 o'clock to 3 o'clock position. So there is a pointer, there is a marker in the probe. So this marker should be roughly around, if you imagine there's a clock, it should be roughly around 2 o'clock to 3 o'clock position on the left side. And basically you are putting the probe at the apex. So when you put the probe at the apex, you can get a four-chamber view on functional echo. And this is the video of a 2D mode of a four-chamber view. So you're seeing the heart inverted, so don't worry about it. And this is the position of the marker. So this becomes your left side and this becomes your right side. So this is your left atrium, this is your left ventricle, this is your right atrium, and this is your right ventricle. This is your four-chamber view. Remember, the right side you can also identify by looking at the position of the tricuspid valve here. The tricuspid valve septal leaflet is more towards the apex. So that's how you can easily identify the right side and the left side. So if you look at this video, if you look at the four chambers, they look almost to be of same size. They are neither ballooned out nor they are like completely collapsed. They seem to be okay. They seem to be full, right? So that can give you an impression that the volume status looks to be normal by just looking at the chamber size. Another view which you can form is called the parasternal long axis view. So here, look at the pointer, it's towards the right shoulder, and you're cutting the heart something like this. Okay. And when you cut the heart like this, posterior most, you will see the left atrium. So here is the left atrium, which is the posterior most structure. Then you see part of mitral valve and the left ventricle. So mitral valve and the left ventricle. This is your left ventricle outflow tract along with a part of aorta and the aortic valve. This is your septum here, and this is your right ventricle. So here you see right ventricle. Now, why you see these structures? Because again, for this, you have to learn a lot of anatomy and how the sections are taken. But remember, the heart is lying like this. So this is called long axis. You're putting the probe in the parasternal area, therefore it is called parasternal long axis. Here the probe is at the apex, therefore you will call it apical fourth chamber. Okay. So in both these views, you can have a kind of rough idea how is the chamber sizes. And if you look at both this one, the chamber sizes looks to be adequate and there is no hypovolemia. When there is hypovolemia, what happens? You will see the chamber sizes are very small and this free wall of the left ventricle and the septum, they will almost kiss each other, which is called the kissing ventricular sign. Okay. So if you find that the chambers are small, the chambers are kissing each other, then there could be a possibility of hypovolemia. Now look at a few, maybe you can look at a few pictures. This is again a apical four-chamber view, which is an upright heart. So this is left side, this is left atrium, left ventricle, right atrium, right ventricle. So look at the left ventricle here. This is completely ballooned out. Large left ventricle, a large LA. Same thing you are seeing in the parasternal long axis view, a large LA, ballooned out kind of LA. So here I would be very scared to give any additional volume even if there is poor perfusion. Rather, I will look into other conditions which can lead to shock. So these patients, I would not be giving volume. I would not think about hypovolemia. On the other hand, if I see these kind of images where you see what is happening to the left ventricle, it is coming, the septum and the free wall of the left ventricle is coming almost close to each other, about to kiss each other. And look at the LA. The LA is very small. The other chambers are fuzzy. They don't look very clear to me. So here, the eyeballing tells me that there is a possibility of hypovolemia. Now, then we can look at the IVC. As I told you, the IVC size can tell you whether there is a situation where hypovolemia could be present. So normally, you have a normogram which you're supposed to follow for the IVC size. Grossly speaking, a IVC which is chinked, which is very small, there could be a possibility of hypovolemia. IVC which is full, it is unlikely that hypovolemia will be present. An IVC which is collapsing less, unlikely to have hypovolemia. If the IVC is collapsing more, then there could be hypovolemia. This is grossly you can understand. To look at the IVC, the pointer is kept just below the sternum here in the subcostal space. And the pointer is towards 12 o'clock position. And you tilt your probe slightly towards the right side because the IVC is towards the right side. And what you see, you will see a structure, IVC, which is draining into the right atrium. So this is your IVC. And look at this IVC here. This IVC is completely collapsing. Okay. So here, hypovolemia is a possibility. And the IVC seems to be smallish. While you compare the other video, the IVC is not collapsing. The IVC is full. It is not collapsing. Rather, there are some pulsations which is coming to the IVC. So this is a IVC which is full. Hypovolemia is unlikely here. It is not collapsing. On the other hand, in this IVC, the IVC is collapsing. It's small and hypovolemia is possible. Okay. So eyeballing can give you a lot of information, especially if you're doing a functional echo for a long time. Then there are some indices which you can do, some there are measurements you can take. So you can look at the diameter of IVC when it is at the maximum and when it is at the minimum. That can give you a lot of information. So in spontaneously breathing babies, as I told you, the IVC will collapse during inspiration because blood is sucked inside the heart. So you'll have a maximum diameter and a minimum diameter. So if you take the maximum minus minimum divide by maximum, this is called the collapsibility index. And if this is more than 50% or 55%, then there is a possibility of hypovolemia. Then in babies who are on ventilator with positive pressure ventilator, during inspiration now, here the the relation will be reversed. So with positive pressure ventilation, the IVC will distend now. And during expiration, it will again collapse. Okay. So here, instead of collapsibility index in babies who are ventilated, there, if you want to look for hypovolemia, you take the distensibility index. So here, distensibility index is maximum minus minimum divided by minimum. So here, denominator is minimum. And if it is more than 18%, then child may respond to fluid bolus. Okay. Then the third index which is taken is called delta IVCD or IVC variability index. And here it is maximum minus minimum divided by the mean. If it is more than 28%, then it is likely that your child may respond to fluid bolus. Remember, these values are taken mainly from pediatric studies, and therefore we do not know the exact predictive ability of these values for neonatal hypovolemia. Then you can look at how is the cardiac output. So you can look at the left ventricle output, you can look at the right ventricle output, you can also look at the systemic blood flow, like the superior vena cava flow, you can look at the systemic arterial flow. So all this is possible by functional echo. I'll give you an example how to look at the left ventricle output so that you can understand whether cardiac output is low, it's a low cardiac output state, or it is a high cardiac output state. Okay. So to calculate the cardiac output, what we do, we have to calculate the stroke volume. So stroke volume in simple terms, it means what is the volume of blood that has been ejected out of the ventricle in one stroke, that is stroke volume. Okay. Now imagine the LVOT, the left ventricle outflow tract, is a cylinder. And we all know that if you want to calculate the volume of a cylinder, the formula is pi r square into h, where h is the height of the cylinder, r is the radius, and pi you have a constant value is there, right? So here, to calculate the stroke volume, what I need is basically the volume of this cylinder. So roughly speaking, stroke volume is stroke distance into the area. Stroke distance is the distance traveled by one RBC. So if the RBC is here, what is the distance traveled by the RBC, which is same as the height of cylinder. So you can imagine here you have the height, and instead of radius, we take the diameter. And you know the radius is diameter by 2. So here it becomes, h becomes, your h remains same. Your r is replaced by d by 2, so it becomes d square by 4, and pi is there. Okay, so this is your stroke distance to get the volume. Okay, now to calculate the height, which is the distance travels by RBC, we use a parameter in functional echo called VTI. Okay, so VTI is the distance traveled by one RBC in one stroke. That gives us the h of the cylinder. Okay, so for that, when you put a Doppler on the LVOT on the aorta, so you get a trace like this, okay, in the Doppler, which is the trace of the blood flowing out of the aorta. And if you can trace this entire area, this will give you the VTI. So we have the VTI, which is same as the edge of the cylinder, which I told you. To get the diameter, you need the diameter of the aorta, for which we'll use another view. So if you have the VTI and if you have the pi d square by 4, then you're getting the stroke volume, the volume which is being generated or which is coming out of the LV in one stroke. Now, if you want to calculate that per minute, you have to multiply into heart rate. Okay. So because this is in one stroke, you want to know what is the output in per minute. So you multiply into heart rate. And if you want to know this per kg body weight, you have to divide it by the weight in kgs. Therefore, the formula for left ventricle output becomes heart rate into VTI into pi d square by 4 divided by weight in kg. So you have to know what is the heart rate. You have to know what is the VTI. VTI you can get from Doppler. We'll discuss how. And you have to know the diameter of the LVOT. The diameter of the aorta you have to know. And if you put these parameters in this formula, you will get the left ventricle output or the cardiac output. And the normal range is between 150 to 325 ml per kg per minute. Okay, let's see how this is done on functional activity. So to look at the left ventricular outflow tract, you first form a four-chamber view and then you modify into a five-chamber view. So here what is being done, the probe is being kept at the apex, the pointer is towards 2 o'clock, 3 o'clock position. You're aligning it along with the heart to get a four-chamber view. And once you get a four-chamber view, you try to tilt the probe anteriorly to open up the aorta. So the aorta will come out anteriorly from the LV. It is anterior to the left ventricle. So you have to tilt your probe little anterior. That is, you have to drop your wrist little more. Then you will see that there is a vessel which comes out through the left ventricle. Okay. So in the four chamber view, you get the four chambers LA, LA, LV, RA, RV. You tilt this slightly anteriorly. Then you will see a vessel which comes out from the left ventricle, which is the aorta. Okay, see, this is the vessel here. You see here, a four chamber is being modified into a five chamber view to get the aorta. Now, once you get the aorta at the five chamber view, you can put color and you will see it will take a nice blue color. Okay, so there's a button in the machine for color Doppler. You just press color in the machine and see this is the position of the pointer. And since blood is flowing away from the probe, okay, blood is flowing away from the probe, therefore it is blue color. This is your aortic flow. And if I press the Doppler button and capture the Doppler at the aortic flow, so you put a pulse wave Doppler, you will see traces like this. You will see traces like this in pulse wave Doppler. All you have to do is trace this entire area. And when you trace this area, you get a measurement called VTI. So here VTI is 17.7. So you already got the VTI. You have the heart rate, which you can take from the ECG or from the monitor. All you need is a diameter of the aorta. For diameter of the aorta, what we do, we make again a parasternal long axis view. Okay. So this view we discussed that you put the probe towards the right shoulder. It is in the parasternal space, slightly in the upper two-third and lower one-third here. And when you put the probe like this, you will see the heart opening up like this. Where the posterior most structure is the left atrium, then you will see the left ventricle outflow tract. This is left ventricle outflow tract. You can see the aortic valves here. Measure the diameters from the hinge to hinge when the valves are fully open. Okay, this will give you the diameter of the aortic valve. Or you can use another mode called the M mode, where you drop it perpendicular here to find the aortic diameter. Now, if you put the aortic diameter here in the calculation, and you put the VTI, multiply it by the heart rate. And if you use this equation, divide by the weight, you will find the cardiac output. So with functional echo, it is possible to know what is the actual cardiac output, what is the blood which is being pumped out of the left ventricle. So this can be also done for calculation of right ventricle output, superior vena cava flow, and other systemic arteries flows. Okay, so this is in summation. You just put a Doppler, get a VTI, measure the LVOT VTI, you measure the diameter of the aorta, put this in the formula, and you will get the left ventricle output. Next is as I told you, give you some examples that you can understand what is the volume status, what is the cardiac output. You can also understand if the cardiac output is low, is it because the contractibility is poor? So that can also be understood. Is it because the systolic function is not good for the left heart? So that can be done. You can also assess the systolic function of the right heart. You can also assess the diastolic function. You can also assess the global function. Now, I'll give you some example to assess the systolic function of the left heart, the left ventricle. This could be done simply by eyeballing, or you can look into certain objective parameters like shortening fraction or ejection fraction. Ejection fraction can be done by various methods. One of the commonest methods, which is usually called Simpson's method. So we'll discuss these three quickly. So this is a four-chamber view. Look at how the heart is contracting, and look at the other image, how the heart is contracting. So by simple eyeballing, I can tell you that this contractibility looks to be good, while this contractibility is not good. Okay, the chambers are quite dilated, the chambers are contracting very slowly. So if I have a heart which is barely contracting, I have some idea already that the left ventricular systolic function is not good. Okay, so look at the heart, look at the contractibility, very poor contractibility. Look at this contractibility, very good. So simple eyeballing can give you a lot of information. Then we can look at some objective parameters to understand what is the LV performance. And for this, again, you can use the same view, the parasternal long axis view. So with the pointer towards the right shoulder, with the probe at the parasternal area in the upper two-third and lower one-third. And when you put a view like this, you see all the structures. Like we discussed, that you see the left atrium as the posterior most structure. Then you see some part of LV, you see the LVOT, you will see some part of septum and the right ventricle. Now, what you do here we want to measure a parameter called fractional shortening. So what happens to the left ventricle during diastole? It will be relaxed, and the ventricular chamber, the diameter, the dimensions will increase. And in systole, the LV will contract and the LV chamber dimension, it will decrease. So we are just measuring the change in dimension of the left ventricle, the change in diameter of the left ventricular cavity in diastole and in systole. Roughly, we say it should be one third. Roughly, the systole becomes one third of diastole. At least that much should be present. So that is what is fractional shortening. So for this, what we do, you are interested in the left ventricular cavity. So you have to measure the dimension of the left ventricle in diastole and in systole. And here we are measuring just the diameter of the cavity, just in one dimension. Okay. So what we do here, we drop an M mode. We have to drop an M mode. Again, M mode is another mode in functional echo that we use. Basically, it's for measurement. And here you drop an M mode line, which should be perpendicular to the septum, and it should be dropped at the tip of the mitral valve. See, there are so many specifications if you want to be accurate. And when you drop a line like this, so this wall corresponds to the left ventricular posterior wall. This chamber is the left ventricle here. Above is the septum. This is the septum. This chamber corresponds to the right ventricle. Okay. And this is the RV wall. So here what is happening, if you look at this chamber, left ventricle, where I'm interested, so its cavity dimension is changing. So in systole, the cavity is becoming smaller. In diastole, again, it is relaxing. The cavity is becoming larger. In systole, it is again becoming smaller. In diastole, it is again becoming larger. So what I have to do, I have to measure this dimension, this diameter. Okay. So where the chamber size is the maximum, this is your left ventricular and diastolic diameter. And where the chamber size is the smallest is the left ventricular and systolic diameter. So your fractional shortening is left ventricular and diastolic diameter minus left ventricular and systolic diameter divided by left ventricular and diastolic diameter. This is what is fractional shortening. Roughly, it should be around 30% if you want to remember one value. So I told one third it should be the dimension in systole. But again, there are ranges. So in a term baby, roughly it's 25 to 40%. In a preterm baby, between 23 to 40% is normal. And the shortening fraction gives you an idea about the myocardial contractibility. Now, there are certain problems with shortening fraction that it is again load dependent. It is looking at the contractibility at only one point. So it may not tell you about if there is some local issues in the myocardium. Okay? So many people are not great fan of fractional shortening. But remember, the data for fractional shortening in neonates is immense. There's a lot of data which is available for fractional shortening. Now, this could also be done in another view. Here, it is the parasternal short axis view where this is being done, and you will get the same dimension. This is a video. Here, you see the chambers are at the maximum dimension. So, this is your diastole, and the chambers, when it becomes smaller, somewhere here, this is the systole. So, all you have to do is measure the dimension in diastole, end of diastole, and you measure the dimension in systole, put it in the formula, and diastolic dimension diameter minus left ventricular and systolic diameter divided by left ventricular and diastolic diameter, and this will give you the fractional shortening. Then this is the Simpson's method of taking out the ejection fraction, and this is very popular in adult patient and pediatric patient. It is based on the principle that the heart is more like a hemisylindrical kind of structure, which is not totally true in neonates where the heart is hemispheroidal, hemisylindrical kind of structure. This is again three-dimensional. So in the fractional shortening, you were looking at one dimension, that is the diameter. Here it is looking at the volume. So it is looking at the entire volume of the ventricular cavity in systole and in diastole. Okay, so diastole is when the LV is at its maximum dimension. You trace the area of the left ventricle, and systole is when it is at the minimum dimension and you trace the area of the left ventricle. Okay. So you can calculate the Simpson's biplane method ejection fraction by the formula, which is LVN diastolic volume here divided by LVN, it should be systolic volume here, divided by the LVN diastolic volume into 100. So this gives you the ejection fraction, and the normal values are between 55 to 70% in neonates. So if you trace the dimensions in diastole and in systole, the machine will give you the value automatically. Then there are methods to attain, look at the right ventricle as well. So it could happen that the right ventricle is dysfunctional, secondary to pulmonary hypertension, or the afterload is increased, or there is less of preload in the RV. So the RV is not functioning well. The LV is not the problem. The RV is the problem. Okay? So you can also look at the function of RV with some parameters like TARP-C and fractional area change. I will just show you one of them, which is TAPC. So here what you do, what is happening when the RV is contracting, what happens? The tricuspid valve here in systole will move towards the apex. If the RV is contracting well, the movement will be more towards the apex. So it tells you about the longitudinal function of the right ventricle. So what we do here, we put in M mode and we measure the distance which is traveled by the tricuspid valve in the M mode. So all you need to do is you put the M mode along the tricuspid valve. So this is the position of the tricuspid valve in diastole. When the RV will contract, the valve will move towards the apex. So this is the position of the tricuspid valve in systole. We measure this distance in the M mode. So you drop in M mode, so you get it traced like this for the tricuspid valve. So this is the position of the tricuspid valve in diastole, which corresponds to this position. It moves towards the apex in systole, somewhere here, moves back in diastole, moves in systole, back in diastole. So this distance is called tricuspid valve plane annular excursion. Okay, so this is basically the movement of the tricuspid valve, which is occurred in systole. Okay, that's what is TAPC. Now, if the RV is contracting well, the movement will be more, the distance covered will be more. If the RV is not contracting well, the tricuspid valve will not move much. So again, there are normograms, but roughly speaking, in a late preterm term baby, the movement should be around, say, 9 to 11 millimeters. If it is less than 6 millimeters, it's definitely abnormal, okay, or low. So this is another video which shows you the measurement of TAPC. M mode is being dropped here. This is the tricuspid valve. You get a trace like this. Okay, this is the position of the tricuspid valve towards the apex. So it has to be in systole because the valve has moved towards the apex in systole. This is the position in diastole. You have to measure this distance, and that is what is your tricuspid valve plane annular excursion. Okay, then there are ways to measure the global myocardial function, but this is an introductory class, so I'll skip this measurement of global functions. Now, once you have done these measurements, there are ways that can help you to manage shock. So if there is low cardiac output, so we calculated the left ventricle output. If the cardiac output is low, the child is having a poor perfusion, the child is in shock, then you look at the volume status. And if you look at the volume status and if you see that the chambers are underfilled, the IVC is collapsible, then there could be a scenario where you'd like to give some volume to the child. Okay. Now, on the other hand, if you see that the low cardiac output is there, along with the LV contractibility is low, which you saw by the fractional shortening, by the eyeballing, by the Simpson's method, whatever you use, that means your poor perfusion is because of impaired contractibility. And here you can start sub-inotrope like dobutamine, you can start as a first line. On the other hand, if you see that there's a high cardiac output state, then there could be a possibility of something which is causing high LV output. So either AV fistula or it is a large PDA there in a preterm baby. So if the PDA is present, then you can start strategies to close the PDA depending on other clinical parameters. And you have to judge whether the PDA is significant or not hemodynamically, both clinically and on echocardiograph. If there's no PDA and if it's a high cardiac output state, in that case, you'd like to start a vasoconstrictor. So preferably maybe dopamine would be a better drug or vasopressin would be a better drug. So above all, the assessment which I just mentioned to you, the cardiac output, the volume status, the contractibility, all this can help you to titrate your inotropic therapy or your volume treatment. Okay, I'll quickly go to two more sections which I'm supposed to finish. So one is the assessment of PDA and other is pulmonary artery hypertension. Both these are extremely important for neonatologists. So first you understand what happens when a PDA is present. So PDA is basically a patent ductus arteriosus, a connection between the aorta and the pulmonary artery. So what happens? There's a shunt which is happening here, and if the shunt is hemodynamically significant, if it is left to right, then what will happen? There's a PDA here. There's PDA here, which you can look on functional echo, and you can look at certain parameters of the PDA. So one is that you can look at the size of the PDA, how big it is. You can look at the size and the direction of the PDA, whether it is left to right shunt or it is bidirectional shunt, what is the type of flow, whether it is the flow is too much, which we call a laminar flow, or it is a turbulent flow when the vessel is becoming small. You can look at the velocity pattern. So all these things are possible in functional echo. Then when the duct is shunting, there is increased flow in the main pulmonary artery. So there are parameters to look for turbulence in the main pulmonary artery and in the left pulmonary artery. So if the flows are increased in the main pulmonary artery, diastolic flows, then the PDA could be hemodynamically significant. When the same blood, which is now increasing, the increased flow has to return to the LA through the pulmonary valve, right, pulmonary veins. So what happens? You will see there will be increased flow here in the pulmonary veins. Okay. Then this blood returns to the LA. There is extra amount of blood in the LA. So what can happen? The LA can dilate. And therefore, Dr. Rajesh was saying that we used to see a LA aortic ratio. The LA becomes large if the PDA is large. There is volume overload of the left atrium. And there are certain parameters which can also look into the pressure overload, such as E ratio, IVRT, that I'm skipping for your concept. But again, what will happen, more blood will return to the LV and the LV can also get enlarged. So LV and diastolic diameter will be more. And then what happens, since more blood is coming into the pulmonary artery, into the left atrium, into the left ventricle, so the LV output will be high. You will have a high cardiac output. Okay. But again, since the duct is shunting left to right, so what will happen? There will be high cardiac output. But if you put Dopplers in the aorta, there will be reversal of flow in diastole. There will be stealing of blood from the systemic circulation. So these are the findings which you're going to get in a PDA. And all this, it is possible to see by functional echo. Okay, so this is how you see a PDA. You make a ductal view, and when you make a ductal view where your pointer is roughly around 1 o'clock position on the left side, somewhere between, say, just below the clavicle, you will see the cross section of the aorta, and you will see a tripod sand, the three vessels. You will see the main pulmonary artery, RPA, LPA, and the ductus, which is draining in the descending aorta if it is present. So this is the view. This is your aorta. This is your main pulmonary artery. And here is some portion of LA. The main pulmonary artery is dividing into the right pulmonary artery, which wraps around the aorta. This is the left pulmonary artery here in the center. And here you see there's a duct which is present. The PDA is present. So you can take the diameter of the duct here and take the diameter at the smallest portion at the pulmonary end, and you take the dimension of the PDA in 2D mode. Okay. So here diameter is being taken, and there are again cutoffs to understand whether PDA is significant or not. The diameter will be indexed against the LPA, or it could be indexed against the weight to understand whether the PDA diameter which you have taken is it significant or not. Then put color on the PDA. If you get a color like this is a nice laminar color, nice red flow. Okay, so the duct is large, and if it is red in color, it's shunting from left to right. If you get this kind of color, that means the duct is shunting right to left. And here, if you get this kind of color, that means there is turbulence. And here, if there is oranges color, speckling is happening, that means the duct is small. And if you get both right, both orange and blue color, that means the duct could be bidirectional. So the color can also help you to understand the duct, like what is the size of the duct and what is the flow there. There are ways to look at the flows of the duct. So these Doppler flows here, the duct is shunting right to left. You see everything is below the Doppler line. Okay. Here the flow, if you see everything is above the Doppler line, and this is a left to right shunt, and this is a bidirectional shunt. So for diagnosis in HSPD, I'm more interested if I get this kind of picture. Then there are ways by which you can measure the systolic velocity and the diastolic velocity. So if the systolic velocity is almost twice of the diastolic velocity, then that we call as a pulsatile duct. So it's a non-restrictive kind of flow, and that I'll be interested perhaps. Then I told you that there could be an overcirculation at the main pulmonary artery. So if you put same the plaques view, if you modify it, just point towards, make it more anterior, you will see the pulmonary artery, the RVOT opening up. Here the RVOT is opening up. Put a Doppler here, you'll get a trace like this. So normally in pulmonary artery trace, the diastole is clean. The diastole should be clean. You only get a systolic because blood is being pumped out from the RV only in systole in the pulmonary artery. But when there is a PDA, then what can happen? You will see flow also in the diastole. Okay, so this clean picture it becomes fuzzy like this. Here, this flow in the diastole. You can measure this velocity, the velocity in diastole, in the main pulmonary artery and the left pulmonary artery. If it is more than 0.5 meter per second in the LPA, more than 0.2 meter per second in the MP, it could be significant. Then you can also look at the parameter called LA aortic ratio, for which you drop the M mode at the aortic valve here. So you see it's been dropped at the hinges of the aortic valve, and you will have the LA dimension behind in the M mode, and above that is the aorta. So you have the aortic dimension. Measure this dimensions and see here the LA diameter maximum here is 1.25. The aortic valve measurement here is 0.52. So here the LA by aortic ratio is 1.24 divided by 0.5 to roughly around 2. So LA is almost twice of the aorta. So if it is more than 1.5 aortic ratio, then it may be a significant duct. More than 2, I mean 1.82, I definitely would be interested. Then in the systemic arteries, I mean, you will see there is steal. Steal means in diastole, what can happen? The flow may be absent or get reversed. So you put a Doppler normally in the artery, in the descending aorta, in the celiac artery, in the SMA, in the MCA, in the ACA, in the renal artery. Normally you see a systolic flow and a diastolic flow. Systolic flow and a diastolic flow. If there's a PDA, there is systemic steal. So what can happen? There is no flow in diastole. So absence of diastolic flow can happen. Further, what can happen because of systemic steal? There could be reversal of the diastolic flow. So here you see the diastolic flow is getting reversed. There's This is the flow in systole and this is the flow in diastole. So this kind of picture tells me that there is systemic steal and the PD might be significant. Okay, so various parameters, we discussed some of them. Don't have time to go through all of this individually. The last 5 minutes, maybe I'll just run through the changes in pulmonary artery hypertension. So, see what is happening. There's pulmonary artery hypertension, so resistance here is high, and blood will try to get some alternate paths to go. So, what happens? Blood shunts through the duct if it is patent. So, there could be a right to left shunt across the PDA, or blood will escape into the RV. So, there could be PR. Here, there could be tricuspid regurgitation. Then what happens as the RV pressure also starts to increase, then the septum, which is normally bulging towards the right side because the LV pressure is higher than the RV, the septum starts to bulge towards the left side. So bulging of septums toward the left side, tricuspid regurgitation. And again, as the RA pressure increases, there will be shunting of blood across the PFO, which will become bidirectional. So gradually, as the PVR becomes high, the RV is not able to pump blood properly. So the RV functions will deteriorate, the RV output will come down, the TAPSI, which we saw, will become less. And the LV, again, the septum is being pushed here. That is what is happening. The preload decreases. Okay. So because of all these factors and ongoing ischemia, hypoxia, the LV will get compromised. So LV function will also start to come down. So these are the changes which are expected as we understand the physiology of pulmonary hypertension. And all this you can get in functional echo. Okay. So there are a lot of parameters, and to understand all these parameters in next 5 minutes, you will have to have a brain like Donald Trump, which unfortunately we don't have. So what we'll do, we'll quickly go through just two, three parameters which are important. One is tricuspid regurgitation. So from tricuspid regurgitation will happen because the RV systolic pressure is going high. So what happens even in systole, blood will leak from the tricuspid valve from the RV to the RA. And if you can measure the velocity of this blood, then you can measure the systolic pulmonary artery pressure by putting it in the formula 4 TR square plus the right atrial pressure. Now, thankfully, you don't have to do this because the machine will do this for you. So all you have to do, you put a four-chamber view, put color into this. You see there's blood leaking from RV to the RA, this blue flow. So blue is away from the probe. And you have to put a color Doppler, a continuous Doppler here because the velocity is high. And if you put a continuous Doppler, you get a trace like this. Okay. You measure the trace, you take the peak measurement of this trace. This is the peak velocity here, which is 4 meters per second. Now, if you put here 4 square, so 4 square is 16 into 4 is 64, plus you add the RA pressure, normally it's 4 to 5 millimeter of mercury. So that becomes 68. So this is your right ventricular systolic pressure or the pulmonary artery pressure in systole. Okay. So with the TR, you can actually measure what is the pulmonary artery pressure. There are various K weights to it. It might not be always present, or it might be also present in other conditions, which we can discuss later. Then you can look at the IVS configuration, the intraventricular septal configuration. I told you that normally the LV pressure is more, so we expect the septum towards the RV normally. So here what is happening, you see on the eyeballing, the RA is dilated, the RV is dilated. That means the pressure is going up here, and the septum is more bulged towards the LV. So it tells me that the RV pressure is becoming more than the LV. The same thing can be looked into a short axis view. So this is your left ventricle. This is your right ventricle. Normally, the septum should be bulging towards the RV. It should be an O-shaped kind of septum. But what happens when the pressure increases in the RV, the septum is pushed, and this O-shaped cavity of the left ventricle, it becomes D-shaped because the RV pressure is going high. Further, if the pressure increases, this septum will be pushed inside the left ventricular cavity, and it becomes a crescentic shape. So normal LV cavity in a short axis view is O-shaped. When the RV pressure is high, it becomes D-shaped, and with further increase in severe pH, it becomes crescentic. So this can be other parameters which you can see, and you can measure this diameter, the one which is parallel to the septum and one perpendicular to the septum. So if you divide the dimension which is parallel to the septum, divide by one which is perpendicular to the septum, that is what is called eccentricity index that can also be taken. Then if you put a flow on the main pulmonary artery, put a Doppler, normally you expect it to get a trace like this, nice trace. In pulmonary artery hypertension, what happens? You will get a trace which is picking up very rapidly. So time to peak of the pulmonary artery will decrease. You can find a notch here, which is the mid systolic notch, and there's a ratio which we take called time to peak. This time divided by the RV ejection time ratio, which becomes lesser in pulmonary hypertension. So I don't have time actually to explain all this to you, but I just wanted to give you an overview. Then you can look at the direction of shunt. So if there is a pulmonary hypertension, the PDA here is shunting in a bidirectional fashion. So a lot of parameters and a lot of things you can assess, but I am running short of time. I have other speakers waiting. So we just saw a glimpse of what functional echo can do if you know functional echo and if you can apply it in the true clinical sense. You should have a focus question to ask. If there is shock, why the shock is there? Is it because of volume depletion? Is the cardiac output compromised? How is the systolic function? How is the contractibility? How is the LV performance? How is the RV performance? So all these questions can be answered by functional echo, and you can titrate your management accordingly. Similarly, you can assess if there is a ductus which is causing a problem in a premature baby, and there are various markers of HSPDA that could be assessed on functional echo. And if it is a term baby, late preterm baby who is having acute hypoxic respiratory failure, if there's setting of PPHN, then you can assess the pulmonary pressures. And most importantly, you should always rule out cyanotic heart disease in these circumstances. And then there are other scenarios where also you can use functional echo. So I'm sorry I have to rush through this entire thing, but that was the time which was allotted to me by Dr. Kavita. Thank you so much, Dr. Kavita. I'm happy to take any questions.
Thank you, Dr. Anup. I think uh, so clear and so the concepts and all the measurements and everything. I've never understood it better before. So thank you so much. I think it was an excellent session that we have seen. I've asked people to post their questions in the chat box. You will be able to see them. We'll take 5 minutes to if they have any questions. Can you see the
Okay.
chat box, Dr. Anup?
I can see the chat box. Yeah, yeah, yeah. So, okay, echoes of CHD is one question which I'm not covering out, and how to see coarctation of aorta. See, echoes of CHD, if you mean congenital heart disease. So remember, we are all intensivists, neonatologists, pediatricians, and our job is not to diagnose congenital heart disease. We are not an expert on that, and we could also land in medical legal soups. So all echoes which we talked about, we call it functional echo because we presume the heart is structurally normal. Okay, and you should have one echo at least done by a pediatric cardiologist. Try to understand your limitations. We are not experts. They are the experts who are supposed to rule out cyanotic heart disease or congenital heart disease. Saying that, of course, when you do many echoes, you're able to pick up congenital heart diseases. That is by practice you can pick up. But anyway, you have to always get the confirmation done by a pediatric cardiologist. Okay. And I don't see any question. Is it? Yeah,
Yes, sir. I have a
coarctation.
question. Can I ask you?
Yeah, please, Kavita. Yeah.
So if we have a preterm baby and we do an echo, the baby is stable on a ventilator, like plateau parameters, not having very high parameters, but the baby is an extreme preterm, and the cardiologist tells us there is a PDA, and size wise and LAO ratio wise, it kind of fits into HSPDA, but the baby is clinically not sick. So what would be your criteria to take a call and treat that PDA? Extreme preterm, low, less than 1 kilo.
Yeah, see again, treatment of PDA is completely a different lecture and completely a kind of different scenario. And if you look at the recent trials, the PDA Tolerate trial, the Benedictus trial, the Oscar trial by Dr. Samir Azmi. So these three large RCTs have come now and which do not show much beneficial effect of treating PDA based on only echocardiography. So all this trial mainly treated PDA, which were more than 1.5 millimeter in size, aortic ratio more than 1.4, 1.5, based on mainly these two parameters. And you see, they did not find much clinical benefit. Rather, there was harm in some of the studies. So, closing a PDA only on the basis of echocardiography will not be my take. Rather, there are other clinical parameters which I may consider. So, what parameters to consider are maybe the parameters which these trials have taken as an exit. So, if a baby is on very high ventilatory settings, more than 50% FiO2, baby who is having pulmonary hemorrhage, baby having shock, and there's a large PDA which is sitting, and I have the parameters for a HSPDA. So not only these two parameters, I see MPA turbulence, I see reversal of flow in the systemic arteries, I see large LA-aortic ratio, I see the IVRT here is getting smaller, or I see that the E ratio, the E waves is getting quite high. So look into multiple parameters, not just one or two. And if the clinical setting as well is there, and I have no other cause to assign that, okay, baby is not septic, baby is not having other causes that can cause the deterioration, then I will be thinking about closing the PDA if the gestation is very small and so on. So I'll be very, very selective in treating PDAs. In our unit, we barely treat any PDA, in fact. Negative.
Thank you. Thank you. There is another question.
Yeah. No, I don't think there's any other question. Oh, there is a question. Questions are coming now. Okay. Okay, so let me see other questions now. So first is how to measure MAPSE and its significance. So I thought it is a very basic lecture just to give you a glimpse, and therefore I have cut down many things. So MAPSE is nothing, it's the movement of the mitral valve in systole. So in TAPSE, you are seeing the distance covered by the tricuspid valve. So tricuspid annular plane systolic excursion. Okay. MAPSE is same thing you are seeing for the left ventricle. Okay, mitral annular plane systolic excursion. How much the mitral valve is moving in systole. The significance is same as TAPSE. It can tell you the longitudinal LV function. Okay. So what does it mean? See, what is happening when the ventricles contract? They contract longitudinally, they contract circularly, they contract radially. So contraction is a very complex phenomenon. For the RV, the longitudinal component is majorly like affecting the change in the volume in the RV, so it is very important. And therefore, if it is contracting well, the afterload is not high, you will have a better distance traveled by the tricuspid valve. So TAPSE is taken. In the same way, if you cut the M mode at the mitral valve annulus, you can take the measurement called MAPSE. That will help you to understand the longitudinal function of the left ventricular cavity. But you already have other markers to understand LV contraction, like the fractional shortening, like the ejection fraction. Therefore, MAPSE is not very popular compared to TAPSE. And also, the contraction of RV is predominantly in longitudinal. The contraction of LV is not predominantly in longitudinal. Rather, it's more in the circular and radial fashion. Therefore, MAPSE has less importance than TAPSE. I hope it makes you get some clarity on that. Can we anticipate shock by echo, like baby having high chances of going into shock by seeing the contractibility pattern? See, you always, use functional echo to answer a focus question. So I don't use echo as a prophylactic, like keep doing echoes and keep doing echoes. So how frequently will you do echo to anticipate shock? How frequently will you be doing it? Now, people have done this, what you have thought, thinking that, okay, babies go into low cardiac output state especially preterm babies in transition in first 24, 48 hours, they can go into low perfusion state. So, okay, let's do echo and let's look at the SVC flow. This was something very popular. And if the SVC flow becomes lesser, then we will treat it. Okay. And they have done this. So there's a trial called the Paralysis trial where milrinone was used to prevent low SVC flow. So they did not find much benefit. And again, the message which I want to give you that you use functional echo to answer a pertinent question, which is your clinical question. So you just don't do echoes and jump on the parameters or jump on the numbers. You have a clinical question that, okay, this baby is in shock. Or the question is whether this baby is having a large PDA, or the question is whether this baby is having hypovolemia. Based on your clinical setting, that you try to answer with functional echo. Otherwise, if you just go and take the EF or if you take the cardiac output of, say, around 100 babies today, you may find the 10 babies having a cardiac output which is just borderline. That doesn't mean that you will start treating them. Okay. Symptomatic PDA when detected late, like after 1 week of life, which drug to prefer? You have to excuse me. I have no knowledge about PDA drug to prefer. So PCM, ibuprofen. So there is a recent systematic review which says that PCM might be more effective than ibuprofen and so on. But please excuse me on the treatment of PDA part. We very infrequently treat PDA. I mean, rarely will treat a PDA. And there is an immense literature which is available, reviews after reviews, reviews after reviews. So you can go and read that. That will give you a better idea than my memory or my bias, whichever, because I'm already biased on this question. Okay, Abdul Sabri is again asking me global myocardial function by tissue Doppler. Again, I did not cover tissue Doppler because I thought this is a very, very basic class and just to give you a glimpse. Now, in tissue Doppler, we calculate a parameter called myocardial performance index. And there are certain waves we can measure the systolic function, diastolic functions by measuring the S dash, D dash, E dash, all those things are possible. So in tissue Doppler, basically here when we put Dopplers, we are measuring the blood flows. And when we use the tissue Doppler mode, which is in the machine, you just press the tissue Doppler mode. That Doppler measures the movement of the tissues, how well your tissues are moving. Okay. So you can measure the movement of the tissues. So when your LV is contracting and is pushing out blood, so what I'm doing in spectral Doppler or conventional Doppler is I'm measuring the blood flow. When tissue Doppler, I am actually measuring how much the tissues are moving. So you can calculate a parameter called myocardial performance index, which is a parameter for global myocardial functions. And for that, what you have to do, you can measure the global myocardial function for the left side, for the septum, or for the right side. If you want to measure for the left side, you put your tissue Doppler gate at the mitral valve annulus, where it is attached to the LV. If you want to know the function of right side, you put it on the tricuspid valve. If you want to know the function of the septum, you put it on the septum. So it gives you a trace, and from the trace, we can actually understand which is the ejection phase and which is the isovolumic phases, isovolumic contraction time and isovolumic relaxation time. So from the trace, we understand what is IVCT and what is IVRT, and the myocardial performance index is IVCT plus IVRT divided by the ejection time. So that is the MPI, and it is possible to calculate. But again, it is not for the beginners. And in this class, tissue Doppler would not have been a good topic to discuss. I think we have finished the questions.
Thank you, Dr. Anup. I think, as you said, this was supposed to be a overview, but I think you did much more than that for all of us. And the fellow should go and attend a workshop where Dr. Anup is a faculty. Trust me, he doesn't let you go unless you understand the concept and how to do it. So thank you, Dr. Anup, once again for giving us your time. It was a very good session, and uh, I'm sure the fellows are really a little bit more confident to go for exams, with the background of this much this information that you give. Thank you so much.
Yeah, and the last message for them is that, okay, you just make sure that you focus on the clinical parameters as well and don't go completely by fashion statements. Okay, thank you, Dr. Kavita, and thank you, Dr. Rajesh and IAP NeoChat. Thank you.
Okay. So from heart, now we move on to the brain. And for that, we have another expert faculty with us, Dr. Rahul Kadam. He's a consultant neonatologist in the Ashwini Bidri Hospital. If you uh, if you go to YouTube and you see cranial ultrasound in neonates, there are so many